call meeting in order. This is a meeting of the Health Subcommittee of Appropriations. The purpose of today's meeting is a public hearing to take input on the 07 budget. We have budgetary responsibility for DCH and the Cancer Coalition. Again, if you don't mind, confine your remarks pretty much to the 07 amended budget. That's what we're currently dealing with. We have a sign-in sheet up here. If you would wish to address the committee and have not signed in, if you would let us know, we'd be happy to work you in. We don't have that many signed up, and we have adequate time to add some more if you'd like to speak and have not yet signed in. We'll ask that you confine your remarks to about 5 minutes. Our secretary, at 4 minutes, will give you the high sign that you got a minute left. If it would be helpful to the committee members, if you do have written copies of your remarks. If you do not, if you'd like to get those to us at a later time, again, that would be helpful as we move through the budget process. The members of the committee will be afforded an opportunity after each presenter to ask any questions of the presenter that they might like to ask. And I'd like to ask the members of the committee, if you just press the button in front of you, then I will recognize you in the order in which you asked to be recognized. Having said that, any members of the committee got anything before we get started? If not, our first presenter is Representative Debbie Buckner.
Thank you, Mr. Chairman, members of the committee. I am really here as much as a representative as I am as a plain old citizen to talk about the West Central Georgia Cancer Coalition, which I serve as vice chair of. A number of years ago, several people from the state came to Columbus and said, you have a terrible cancer rate in your city and something needs to be done about it. And what we were finding is that there were a number of people that were not coming in for treatment until they were like stages 3, 4, and 5, and the majority of them were in stage 4 and 5. And if you're not medical, stage 4 and 5 of cancer is the end where there are fewer options, and many times we end up losing those patients. They gave us a challenge to really work towards becoming a cancer center of excellence. And the community came together and took up that challenge, and we formed the West Central Georgia Cancer Coalition, which is a united effort of health professionals, county health departments, every hospital, the nonprofit organizations, faith organizations, businesses, cancer survivors, and just, like I said, plain old citizens. And throughout a 10-county region in West Central Georgia, we have been trying to put together efforts that we could not only identify cancer earlier, but to help bridge the gap from when they're identified to get them into treatment so that the treatment would be more timely and have more options for the people and be less costly care. My purpose in being here with you today is that I'm very concerned about the way the funding for the cancer coalitions is proposed. The competitive bidding process for the money for the cancer coalitions does not seem fair. We were asked to do this, we have done it, and then to take away just core funding and say go out and get grants is just not a workable solution. We need at least some core funding so we can keep the doors open, keep the lights on, have the telephones work, and then we can go out and get grants like we have done. Nanette Turner with our Cancer Coalition will tell you about some of the grants that we've had and some of the national awards that we've won and some of the good work that we've done later on. But I just plead with you, there is a huge amount of money that's being given or being proposed to be given to the Georgia Cancer Coalition, but that money cannot all stay here in Atlanta. It has got to, we need some core money in all of the cancer coalitions, and then let us compete for something over that core money and let us go out and get grants. But there just are no grants for core funding, and we can't keep the doors open without it. And that's the essence of my message.
Representative Buckner, you said allocated for core funding now is not adequate. What is?
Well, it's not that it's not adequate. It's what that's being proposed is that there would be no core funding, the way I understand it, and they would just compete. Well, if there isn't, if we had, and I don't know, different coalitions are different, but if we had a $50,000 allotment for each of the coalitions around the state, then they could keep their doors open, pay their salaries, and then they could compete for whatever else above that.
I think in 07, part of the funding is core funding, and part of it is competitive in 07, but in 08, it's all competitive. And so you said $50,000 is what you said would be core funding. Is that correct?
That's what was said. I don't think 50,000 would do that. More like
100 would be better for everybody here on this front row.
By the time you figure salaries and all, 50 won't cut it.
Right, and right now, in some of the coalitions, the salaries are being covered by local hospitals. I know in Columbus we have a case manager, and quite frankly, some of the hospitals have had to pull out the funding this year because money has gotten tight for them, and they are not going to be able to pay for that. So they can tell you the numbers. My point is, I just feel like that we definitely have got to do that core funding, and let them tell you what they need in their regions. You're going to hear from a lot of them, if not all of them. I don't know how many are here today, but that's the real fear for us in Columbus, that we can't do without a base, and then we can keep the doors open and write the grants and get the other.
Thank you.
Thank you.
Is there any other member of the General Assembly here that would like to address the committee? David Tatum.
I've got copies. Mr. Chairman, if it would please the committee, there's some other folks that are going to be joining me to try to minimize duplicative testimony. My name is David Tatum with Children's Health Care of Atlanta, the entity formed by the merger of Eggleston and Scottish Rite Children's Hospitals back in 1998. Joining me is Stan Jones, representing HCA, and Danae Gamble, representing the Georgia Hospital Association. Linda Womack with Emory Crawford Long sends her apology. She could not be here, but she asked me to speak in her stead. What I've handed out is a one-page description of the issue I'm going to talk about. Federal law describes what a disproportionate share hospital is that's eligible for participation in the Indigent Care Trust Fund, whether that hospital is public or private. If it meets certain criteria, including a threshold of Medicaid volume of patients and uninsured patients, then it qualifies as a defined disproportionate share hospital and was, until recently, eligible to participate in the Indigent Care Trust Fund. As Ms. Summers told y'all yesterday, back in April of 2005, the federal government negotiated an agreement with the state of Georgia so that the public hospitals that contributed to the fund and the overmatch from those contributions could no longer be used to support the private hospitals. At that point, the private hospitals, I think there are 26 of them, were effectively out of the fund. Last year, the General Assembly appropriated $14 million for the state portion of the dollars that are matched by the federal government to keep those private hospitals engaged. This year, we were a little bit surprised to see only $10 million in the governor's recommendation, $4 million less than we got last year. We had asked for $21 million. That $21 million would maximize the distribution of funds to the private hospitals. That was not accomplished last year, and would also provide us with a little headroom for some private hospitals that didn't qualify last year that we think are going to qualify this year. Rough estimates that we have run, and they have to be rough because discaps shift based on certain variables, indicate that with the $10 million, be about a third less available in the pool for private hospitals this year over last year. Speaking for Children's, that would mean an approximate $2 million cut to us. At Children's last year, we experienced $78 million in unreimbursed Medicaid and indigent care costs, not charges but costs. We got $8.7 million out of the Indigent Care Trust Fund. We believe this was taken. This would take us down closer to $7 million. Getting back to the $14 million from last year might not even do the trick, because the public hospitals have experienced a reduction in their upper payment limit, which means their disproportionate share caps can go up, and they would draw more money out of the fund. I've heard a couple of terms in the last few days which I think may identify some potential funding sources for the $11 million that we are asking to be restored. One is pre-funding. Sounds to me like there might be some dollars available in the 07 budget and could be taken into account depending on what 08 projections are. And one I heard yesterday called cost avoidance, which is the first time I've heard that term. When the department was asking for FTEs to try to reduce duplicative and repetitive claims, which sounds like a great thing, I think the chairman asked about the amount of money that'd be saved, and it was $12 million, but it wasn't savings, it was cost avoidance. I've got to talk to some of my accounting friends to find out what the difference between those two terms are. But we're looking for 11, that's 12. Speaking for Children's, we're the largest Medicaid provider in the state of Georgia. We serve more Medicaid patients and bill Medicaid more than Grady does. And I never thought I'd hear myself say that. I think it is incongruous for the largest Medicaid provider in the state to be restricted from the very fund the state uses to help offset the losses at high Medicaid and indigent care providers. It's just not right. Thank you.
Any questions from the members? Ms. Tatum, just one clarification. Although this is in the amended budget request, the $10 million that the governor put in, state dollars, isn't it true that this is all the money that is in 07? That is to say, it wasn't some put in earlier and then $10 million more. Doesn't this money come during the amended each time? So this $10 million is for all of 07?
Yes, sir. It's for the distribution that would occur sometime this spring. The $14 million from last year has been spent and gone, and this would be the only dollars. There's no money in 08 at all.
But the $14 million you're referring to was in the 06?
Yes, sir, last year.
Yeah.
Amended 06.
Yeah. Thank you.
Thank you.
I think we've been called the bobbling heads to second the lead presentation on the DISH issues. My name is Stan Jones. I help Hospital Corporation of America. We have 4 DISH providers. There's about 26 hospitals in this group. They're both for-profit, not-for-profit, sole community providers, and others. And they come to this program out of the sort of basic notion that David's described, that if you are doing, more than a fair share of indigent care, you have a right to participate in the fund because of the number of Medicaid persons or the number of indigent persons that you serve. In HCA's case, we've actually experienced an increase in our indigent care over the course of the last 8 years, so that it's going up about 1% a year for all providers, whether you're community nonprofit, small or large. In our case, it's up around 9% for the company as a whole, and we're the sole provider in numerous counties, most of which are the DISH-qualified entities in Dublin and Cedartown and Cartersville, for example. We're the only provider, and that's true for many of the sort of private facilities throughout the state.
And the association supports these comments as well. Recommendation.
We have a question from Representative Hughley.
The question is for either of the presenters, but on the handout it said that you all, the private hospitals, were interested in providing solutions that would allow participation without the need for additional state appropriations, and I don't see that on here. What the proposal is.
We can both address that.
That's a tough one. We understand that the General Assembly may not want to continue to carry the private hospitals annually with state appropriations. We also didn't talk about in our presentation that the folks at CMS, as you heard yesterday, have issued that proposed rule, which my interpretation of it is that there won't be a public hospital left in the state. We'll all be private hospitals. And we're certainly willing to participate in whatever's discussed as a long-term solution to address that if it comes into play, and a number of things you could try out. But speaking for Children's again, we've been trying to contribute for 10 years. We've looked at contributing through our hospital bond authorities and various other mechanisms, and we can't get anywhere with the feds. We don't want to come back to you year after year after year just asking for more money over and over again. We'd like to have a piece of the solution.
There may not be time enough in finalizing the 07 supplemental budget to get into sort of longer-term solutions. The reference in the paper was to some other types of things that are available. We've already talked about one in terms of the duplicate beneficiaries are actually funded through the CMOs sort of on a upfront basis with some adjustment later. There may actually be additional cash available for 07 by getting to the bottom of some issues like that, in addition to the partial payment and underpayment issues that are surfacing in that realm. Other states actually do some various things with their dish funds where they're put into pools for uninsured people so that they come back out a different way, or that they increase the Medicaid rates. So over the course of the next year or two, as we kind of get into these issues and see how deep they are, if the new federal regulation goes through as proposed, it's going to be time for some creative thinking to supplement the care for uninsured persons that has previously been paid for through the fund, which may dry up. And I think we're all eager to participate in that discussion.
Heather Rolls, is that R-O-W-L-E-S?
Good afternoon. My name is Heather Rolls, and I am here representing several providers. We're all private, nonprofit providers and provide a full continuum of services for children and adolescents. And I'm also with Tom Russell and Sally Buchanan, who are among those providers. We're involved currently in the unbundling of DHR with the Medicaid services that are being provided to children and adolescents in the state of Georgia, primarily in the foster care system. We're working with DHR on that. There's some pretty significant issues coming about with that, but we are in open dialogue with them, working with them on that. We anticipate that those changes are going to affect the 08 budget and potentially the 07 budget. Got anything you want to add?
Representative Gardner has a question.
Tell me a little bit more about what you do. You were talking too fast for me to follow you, I guess.
Sorry.
I know you work with child and adolescents.
Right. We work with children and adolescents across the state of Georgia who are in need of therapeutic services, primarily residential services. We have contracts with the Department of Human Resources. Previously, we would get a bundled rate to provide those therapeutic services with the room and board and watchful oversight, as Commissioner Walker calls it. Now those rates are being unbundled, and we've been involved in that.
So is the problem that you are having to change your billing system, or?
It's a lot more complicated. I mean, yes, we're going to be billing the Department of Human Resources as well as Medicaid and becoming Medicaid providers. Most of us are going to be doing that, but there's been a lot of issues involved in that unbundling process.
Which has to do with reimbursement rate, or more complex than that?
Yes, and as far as the reimbursement rate, the actual rates themselves, making sure that adequate services are being provided to our children, especially those that are the most in need. Mm-hmm. There's a variety of reasons why they're in care and a variety of services that they need, and so we want to make sure that those kids don't fall through the cracks. And it is about we are going to be billing Medicaid for certain services, but making sure that we're adequately funded to provide all the services that are needed.
And these are not funded through the through the care management organizations. This is in the traditional Medicaid program, is that correct?
Correct. Is that right? In addition. It is in addition to the care management organizations, but
it's
not entirely with the care management organizations.
So some of the billing is with the care management organizations, and some is in the traditional Medicaid foster care program?
Yes. Go ahead, Tom.
If I can help clarify, I'm Tom Russell, Director of the
I'm
Bridge.
the new one on the committee.
And a member of MAC. So currently, youngsters in foster care, we have over 17,000. There are about 1,100 youngsters that have rather serious histories of physical and sexual abuse and require mental health services in a residential setting until they can move back to the community. Mm-hmm. Historically, those services have been reimbursed through what's called a bundled rate, which includes room, board, watchful oversight. It's all inclusive.
Mental health services.
Mental health services, yes. We are in the process with DHR of working out how unbundling will affect what's called room, board, and watchful oversight, which will be state dollars, and then shifting and trying to pull apart the behavioral health services, so each of us as nonprofit organizations will now also have to become a Medicaid provider and develop an infrastructure to bill Medicaid. So while we're talking about rates, our concerns are, as we're working on this, that if we aren't careful, some of the capacity that we currently have to take care of youngsters will be diminished, and there's also the potential eliminated, which will really cripple the continuum to take care of the youngsters. Many of the nonprofit organizations, if we aren't careful in this process, will go away. We know from other states that have gone down this road that sometimes part of the nonprofit infrastructure has been eroded only years later to say, now how do we rebuild this, because the unintended consequence was we destroyed some capacity. So what we're wanting to do today is certainly make you aware of our concerns about that, that we are actively participating with DHR currently in trying to work that out. We may need to be coming back later with some additional concerns, but we wanted to make you aware of that.
Well, I'm extremely concerned about the mental health needs of these children, and I hope that you will keep us posted on how you're able to ensure that the children get what they need in terms of mental health treatment.
We're working on that daily, so thank you for your concern.
Thank you. Donna Davidson.
Good afternoon. My name is Donna Davidson. I am the president of Easter Seals North Georgia, and I'm here also representing the Georgia Speech and Hearing Association. In 2005, due to an issue to become HIPAA compliant, the primary code that the Speech and Language Pathologists Bill, which is code number 92507, had to go through some changes that resulted to going from a timed code to a non-timed code, which resulted in a 50% reduction in our reimbursement fee. As we looked throughout the Southeast, we realized that we are the lowest, we were being paid the lowest for this particular code in the entire Southeast, as well as throughout the country. As a result, Georgia Speech and Hearing representatives met with members from both the House and Senate Health and Human Services subcommittees, as well as appropriations, to discuss the decrease in the reimbursement rates. The House and Senate Appropriations Committee and then the Full Appropriations Committee improved the increase of Code 92507 from $40.99 to $62.53, which was to be effective on July 1st, 2006. Shortly thereafter, the Department of Community Health notified Georgia Speech and Hearing representatives that the code increase would not be able to be effective on July 1st, 2006, due to budgetary reasons, and that instead the increase would go into effect on January 1st, 2007. In October, we received another notice from the Department of Community Health that, in fact, the code for 92507 was being decreased once again from $40.99 to $39.55 due to a calculation error on the part of DCH as it related to the RBRVS rate. We have been meeting with the Department of Community Health monthly to question the status of the legislatively approved increase. What happened on November 21st, Georgia Speech and Hearing representatives learned that through public notice that the rate was going to be increased from $39.55 to $47.82, despite the fact that the legislators approved the rate to be increased to $62.53. We had no prior indication of why this was to occur, and this change is additional negative impact as well as what the therapists across the state in physical, occupational, and speech therapy have endured as a result of the CMO implementation that we went through this past year. We have talked to the Department of Community Health and asked what it would take to get us up to what was the legislatively approved rate increase to the $62.53. And we have been told that we would need an additional $745,000 in state funds to be added to the supplemental budget to fully fund this increase for a year. And so we're respectfully requesting that that money be appropriated so that we can get the increase that was legislatively approved in the 2007 budget. Thank you.
Representative Hughley.
Thank you, Mr. Chairman. Let me make sure I understand this. You're asking for $745,000 to retroactively to the beginning of this budget because this is an amendment of the budget, or this is for...
No, we were supposed to have gotten the increase that was to be effective on July 1st.
Okay, and I assume some services have already been provided.
Right. We were not asking for it to be retroactive. No, we were just asking from at the point that the supplemental budget is approved that we begin to get the $62.53 increase.
For the remainder of this budget, it's going to take $745,000 to cover those services that you anticipate.
No, it's our understanding that the $745,000 plus the $300 and I think it was $50,000 that was initially appropriated in the budget, those two amounts together would cover the cost for an entire year of that increase.
Representative Gardner.
Would you clarify for me, the rates are federally established RBRVS rates?
There is a federally established RBRVS rate, and the states have the opportunity to determine how they're going to pay that. Some states pay 100% of the RBRVS rate. Some states pay 80% of the RBRVS rates. And our state actually is not paying the current year's RBRVS rate. They're paying, I think it's 2005 or 2006 RBRVS rate. I'm sorry.
And are some of these services provided, billed through the care management organizations, and some of them in the age-blind and disabled?
Yes, ma'am. And this initial increase was only legislated for the age-blind and disabled population. That $745,000 additional funds would be aimed toward the age-blind and disabled population. And I might also add that we still have not seen the increase, and it is, January 25th? Yes. And we have still not seen the increase yet.
Thank you.
Thank you.
This is a public hearing, and neither the committee nor the department or anything like that is going to be responding to these things now. Having said that, for members of the committee, there are people here from the department, and in part they are here to hear concerns and to get back with us in any questions that we come up with, and they will do so in writing. And Carrie Summers is down here on the front row. I'm sorry. Carrie Downing, excuse me. I apologize. But at any rate, obviously this particular issue seems to be a little confusion on this issue, and if you don't mind, from the department's perspective, kind of shed some light on this, if you will. And as we go through this process for members of the committee, any specific thing you'd like to for the department to provide, just speak up. Diane Fletcher.
Thank you, Mr. Chairman and committee members and staff members. It is a pleasure to be here today. I appreciate this opportunity to tell you a bit more about the Southwest Georgia Cancer Coalition and also, in general, the Regional Cancer Coalitions of Excellence. Thank you, Representative Buckner. She's still here. Thank you. She actually gave you quite a bit of the background, which we appreciate, and I appreciate her commitment and passion to it. We believe that the regional coalitions of excellence are absolutely essential in order for the state to reduce the cancer incidence and mortality. Without adequate and predictable funding, the regional coalitions are unable to continue to fight against cancer at the community level. And again, part of the background is this was a call to action essentially by the state, and our region in Southwest Georgia, as well as across the state, came together to respond to this, engage the community, and really responded in a way that we believed that we would actually reduce the incidence and deaths of cancer by assessing the needs of the communities and responding directly to those needs. This model is really unique. I don't know if the state realizes, but it's actually the only one of its kind in the country. And it's one of the reasons that I came here. A year and a half ago, I was up in Pittsburgh and directing Pennsylvania's statewide coalition, similar to the Georgia Cancer Coalition here. And one of the reasons that I was so impressed with what the state of Georgia had committed to do is because our struggle in Pennsylvania, as in many other states, was that we couldn't figure out how to get these initiatives down to the people, how to translate them to the grassroots level. And it was quite frustrating. We couldn't even figure out a mechanism to get funding, much less to assess what everyone needed across the state. So it was a model that I think is most effective, and I would argue really the only way to get cancer control to the local level. And it is true that it helped that it doesn't snow in Southwest Georgia, but that's not really why I was here. I was very impressed with the commitment that was already in place. The regional coalitions, you may have heard of some of the statewide cancer initiatives, and the regional coalitions, again, are essential in order to successfully implement those. And I'm speaking of the new state cancer plan. Every 5 years, by the CDC, every state's mandated to write a new cancer plan. All of the regions have been extremely committed to that cause, and hundreds across the state have been engaged in that process. The tissue bank, again, we need specimens all across the state. It's the regions that will bring those specimens and have them transported to MCG. The cohort study, interestingly, actually originated in Southwest Georgia. And this was before my time, but the board of directors of our regional coalition came up with that idea. And it was because they saw the need. They saw the numbers of people at risk, all of the people, the high numbers of cancers in the area, and a stable population, and realized that this cohort could be followed over time. And they initiated the contact with the Rollins School of Public Health and pitched the idea to the GCC. And we're grateful that they did take that on and are continuing to support that. But we need the coalitions to be involved at the regional level. And also the Clinical Trials Network and the distinguished scholars. They're brilliant people, but they need the populations across the state in order to do their work. Some of the challenges we've had in Southwest Georgia in particular, we have the highest incidence of cancer in the state, 35% higher than the rest of Georgia. And in fact, one of our counties has had some recent notoriety, not one that we wanted, but Terrell County actually has the highest death rate from colon cancer in the nation. And I'll speak about that again in a moment. We also have, as you know, poverty, lack of education, lack of access. All of these things tend to increase the cancer burden and make it more difficult to have outreach. And we are starting to have targeted programs, and you'll see in your packet lots of information about some of the things that we are doing that I can't cover in detail, but we do know our communities, and we're just starting to approach this prevention and education and screening and research. And we've only been in existence for a couple of years, so we're just at the beginning. The biggest challenge is that many of the regional coalitions are at risk because of limited and unpredictable funding. And you'll see in your information there that since fiscal year 05 to our coalition, the GCC has only provided 14% of our funding. And despite a $6.1 million increase in the recommended budget for fiscal year 08, the regional coalitions in total are only recommended to receive $600,000. And that's not a guarantee to any region. That's a competitive process that we must compete, and there's no guarantee. We continue to be here. We're on the front lines. As I said, in Baker County, just briefly, one of our projects there is to do community outreach through navigators. It's a novel idea to actually go out and reach the people. And through our initial efforts, just for colon cancer, we have done 28 colonoscopies. Of those 28 people screened, more than half of them, 15, were found to have polyps, and of those, 8 of those were precancerous. Those people, I guarantee you, we would have seen down the road in a later stage and been much more expensive to treat and possibly been unable to cure them. We actually removed those polyps and prevented the cancer from ever occurring. And that's the types of things that we're doing. We have been highlighted. We have a DVD. If we have time, we can show it later. That on CNN recently had a special, and they actually highlighted our region's efforts in Baker County. What we are requesting and how we think we can continue to survive is to have line item designated funding for each region, that the use of those funds can be determined by the needs of the region. And there's a budget request that we put together at the request of our legislators in there for our particular region as far as supporting projects that we have underway. I'd be happy to answer any questions.
Representative Buckner had mentioned core money and as it relates to the funding part of this. And as you pointed out, there's now a competitive process. Could you share with this committee your thoughts on, as it relates to the state part of the funding, what percentage should be quote unquote core money, and what percentage, if any, should be in some fashion other than that, be it competitive or whatever? What's your thoughts on that?
It's challenging to give an actual percentage, but what most of the coalitions believe from what they have been doing and to continue the services and programs that they have underway, that it would be a minimum of $100,000 to $250,000 as core funding, what we call operational funding, for each coalition. And then in addition, we would hope to be able to compete for additional fundings based on merit and projects that the state may want to prioritize.
Representative Smith.
Thank you, Mr. Chairman. Ms. Fletcher, I want to commend you. I know Representative Reinders is very complimentary of what y'all do there. But you just made the statement of $100,000 to $250,000 for core funding. Why the spread? Are we looking at coalitions that are greatly different in size? Or?
Yes, they differ, and I hesitate to speak for my colleagues, but we meet as a council, so we're all fairly aware of how we all compare, and we tend to focus on different priorities. Some of the coalitions have not received as much local support. Our coalition has been fortunate that we have received some support from our local hospitals, and so therefore I've been able to hire more staff. We've been able to start more programs. In order to continue those, I require more base funding. A smaller coalition that maybe is just getting started and has a smaller number of initiatives and smaller number of staff may need less money. So it does vary within the 6 coalitions.
Thank you. Representative Reinders and I have adjoining offices, and he tells me 3 or 4 times a day what a great job y'all are doing. And I notice he has arrived from he had a previous meeting. Representative Reinders, would you like to address the committee?
Thank you, Mr. Chairman, for those kind words. And thank you, Representative Smith, as well. There's a problem, and I think the problem is that there's, a little bit of flexibility in the decision-making process. What I really feel the original intent of the Cancer Coalition was to look at the needs of their specific areas. I think if we looked at this as a way to give a flat amount to each one of the regions, that's the smart way to do it, and then to give a little flexibility with a second pool of money, if you would, so that the Mr. Todd can then have the flexibility that he may need in order to give the kind of additional funding based on merit, based on things that are going on, based on what the screening and preventive kind of controls are doing in each one of those areas. But I think it's imperative that each one of these cancer centers do not have to look, or cancer centers of excellence, do not have to look from year to year to guess how do I go about making a budget up when I don't know what I'm getting. And I really think that's kind of a common sense approach. And for my constituents and the people in southwest Georgia who do have such a high cancer rate, I can only tell you up front and firsthand, and Representative Royal can as well, Chairman Royal, that they are actually going out there and putting the boards together, trying to raise money on their own and doing it right. And it's in a model that should be rewarded. Thank you for your time.
Yes, sir. Thank you, sir. Jimmy Lewis.
Thank you, Mr. Chairman. My name is Jimmy Lewis. I'm with Hometown Health. We're an association of 55 rural hospitals, and I come to you today to ask you for your consideration, as did Mr. Tatum did, on the subject of the private hospital funding, where currently it is proposed to be funded at $10 million. Last year it was funded at $14 million, and we would come to you this year asking for funding for $21 million. I echo the words that Stan and David and Danae had to say pertaining to hospitals. I want to share with you what we feel are some strong justifications for the need. I represent rural hospitals, and there are some 13 of the 26 hospitals that are private that are rural, and I want to give you a background as to the situation that we're facing, because hospitals in general are facing some fairly dire straits, and specifically rural hospitals. And I just want to share with you some facts that we feel are representative of the really dire situation that our hospitals are facing. And I think when you see this, that not only this issue, but the issue of health care funding in general is a serious issue for it. So several points that you could follow with me in the document that I gave you. There are 26 private hospitals, 13 of which are small rural, with 6 critical access hospitals, which formerly were cost-based, and 7 PPS hospitals, which are prospective payment system hospitals. There's a list attached on the back. All of these hospitals want to contribute to IGT, but CMS rules prevent their participation by quirk interpretations that we've struggled with, as David indicated, for many years. Hospitals have not received a rate increase since 2002 or before, while inflation has continued at 3 to 5%, meaning that they are down about 20% against inflation. Critical access hospitals were cost-based, but the CMO implementation had no language to maintain that cost-based in the contracts. So they lost that to negotiation, which meant dollars were lost in many businesses, especially the smaller hospitals. Medicare is privatizing at an expected 30% conversion in 12 months, with a minimum of 5% loss of net revenue expected against the same services being provided. Non-critical access hospitals, those that are called PPS hospitals, only receive 85.6% of their cost on their outpatient services, and that represents about 60 to 70% of the small hospital rural volume. And that translates to a loss of 14 cents on each dollar of Medicaid outpatient revenue that they serve. 2 years ago, the state implemented additionally a 10% interim payment cut on top of the 85.6% cut to avoid overpayments, which cuts the average hospital, especially the small and rural hospitals, and these 13 private hospitals are down to about 75.6% of cost. The CMO implementation rendered 50% of the upper payment limit eligible funds ineligible for drawdown, which has cut upper payment limit some 50% for hospitals, and especially these smaller ones. The CMO implementation overall is reportedly going to take $200 million out of the delivery system, most of which is in hospital provider fees. The state did this without any improvement in EMTALA and no enforcement of the physician gatekeeper concept. Thus, the hospitals have to bear the load of unfunded utilization cuts and entitlement growth. The Indigent Care Trust Fund program, which is a $400 million plus program overall, for which many rural and private hospitals had become totally dependent on for operations, have been disrupted with a 10 to 12-month postponement in the last 2 years and currently have not been paid any ICTF yet for 2006. Thus, there are major cash flow problems. The Indigent Care Trust Fund program, again, the $400+ million program, was designed to be a backdoor payment, recognizing that the state does not fully pay for Medicaid's cost at the front end, and now that is being proposed to be taken away or eroded. With no notice of this reduction from last year's funding, no time is available in this session to seek options if there were any. Many have said that this is a squeeze play to force these private hospitals to force the hospital industry to a provider tax. These 26 private hospitals have no leverage to cause the remaining hospital industry to do anything, much less do something as far-reaching as a provider tax. I've attached for you 3 financial models that we have worked with in rural hospitals over the last 6 months. These 3 financial models are attached, and I encourage you to study them offline because they're most revealing. You'll find that the typical critical access hospital with OB loses operationally about $574,000 a year annually. If that same hospital does not do OB, loses about $200,000 annually. Many rural hospitals are looking at dropping OB, as the chairman's hospital has done so recently. 2 already have. With a typical payer mix, a rural hospital cannot show net revenue above expenses without upper payment limit, ICTF, and county subsidy. The non-critical access hospital's example illustrates the same story, but its losses are much larger at $1.2 million annually. Of the private hospitals, 4 critical access without OB and 2 with OB, and there are 3 PPS hospitals. I ask that you, with this information, that you consider funding these private hospitals to the amount in the 07 budget of $21 million. I would refer to Dr. Meadows' conversations yesterday, noted for some rather large words describing some large issues. She used cataclysmic. I've used debacle. I will leave you with one here, and that is that the combination of the events that are currently occurring could represent a depressionary period for health care, the likes of which we may not be able to pull out of. So it is with that I ask for your consideration in the increasing the funding to $21 million.
Mr. Lewis, you touched on a number of things, and you have a very thorough handout, and I'm appreciative of that. I do want to follow up with one of your comments about operationally small hospitals losing $575,000 if they do OB and $180,000 if they don't do it. And as a result of that fact, then many rural hospitals now no longer deliver babies.
That is correct.
And we have an increasing problem in rural Georgia with an ability to treat and deliver babies as it relates to Medicaid, and particularly prenatal care. A lot of these mothers, of course, transportation is an issue, and oftentimes they have to travel long distances. And do you have any notion what the state could do to, aside from the obvious, and that is pay more money for that service? I mean, it's kind of, as you indicated, it's kind of the watermelon truck theory. If you just get a bigger truck if you lose the money, but that doesn't work, and so they quit doing it. But I'm very concerned about these pregnant women and the prenatal care that they may not be getting. Do you have any suggestion for this committee about how we can deal with that issue?
Mr. Chairman, thank you for the question. We have studied that extensively, and the simple answer to that is it is just about money. When we've done the analysis on these hospitals, especially the smaller hospitals, we find that a hospital with OB typically does 26% Medicaid. If it does not do OB, it does 14% Medicaid. Medicaid pays less than cost. That's a recognized fact. If it's a PPS hospital, again, it pays 85.6%, less the 10% interim payment cut, so they are seriously underfunded in cash. If it's a critical access hospital, they typically were supposed to be cost-based, but they actually only ended up about 95% of cost until the CMOs went in, and the cost basis went out with the CMOs, and you're on your own to do your own negotiations. And the consequence of that is the monies are just simply not there to support the process. And we're currently in evaluation right now with probably a half a dozen other hospitals to determine if, in fact, they want to keep their OB or can afford to. I would say the break even on babies right now, just dollars wise, are probably something in excess of 200 baby deliveries a year.
What I want to hone in on, and you're correct, but the fact is that the reimbursement is not there. The fact is that hospitals have a lot of them, and I know certainly in my area, I mean it's about a 6-7 county area that mothers have got to go to Athens or Augusta or Atlanta or Macon. We are where we are. So when you have, and particularly in rural Georgia, there's a lot of large geographical areas that doesn't have that service now for the reasons that you point out. But what do? How do we get prenatal care to those mothers today?
Again, Mr. Chairman, it's about dollars to provide the OBs and the service people to go into those communities, and it's entirely about the dollars. Two things required. You obviously got to have OBs to do the deliveries. It's important to have usually two for backup support, because one OB doing a delivery in a swath of countryside like where you live is very difficult if there's only one. They burn out because of the volume that goes into it, and they can't stand the load. And then in addition to that, the reimbursements, particularly now that we've got the other issues of CMO and the complexity of the payment system, they just can't afford to do it. So they just don't want to be there.
Representative Stevens.
Thank you, Mr. Chairman. I've got a question. You know, even with the natal care, with the birthing of babies, once they drop that service, which is horrible, we've got to go to another city. And I think there's been cases where some of these mothers have had the baby in the car because of the distance that they're having to drive. But what's next? I mean, I see just service after service being dropped. What do you see these hospitals being faced with next as the next service they're going to have to cut just to be able to break even?
As we do strategic plans with these hospitals, we're encouraging them to do a byline return on an investment to determine what all goes and in what order. And essentially, they started out with particularly the prenatal programs, the wee beginnings, and those kind of programs where they were looking after the children. They cut those first. Then they went to other issues that they may have in the hospital, like a dialysis unit or a particular physician-based program practice that they owned, and they shed those. They've essentially gone through as many of those lines that they can determine return on investment, and now they're down to OB. I'd comment to you that the critical access hospitals are to the point that if there are 35 in the state, there are probably only 4 or 5 of those now that deliver babies. The next level hospital up is that hospital that's a non-critical access hospital that typically starts at about $17 million net revenue, and those hospitals are called PPS hospitals, and they now are in the process of beginning the evaluation on OBs. And again, quite frankly, if they don't have 200 deliveries, which is a lot of deliveries, but if they don't have 200 deliveries in the community, it's just really economically not worth their while to be in the delivery business. It causes them. And it's a combination of events. It's the cost of the OB as the delivering physician. It's the cost of the malpractice insurance to support having that OB on site, and then the additional coverage that goes with the services, whether it be another OB to back them up or midwives or whatever the case may be. It's a domino effect that we're now, for as much as they can identify a line item return on investment within the hospital to keep it open, that's what they keep, and the rest of it they have to shed.
If I may, Mr. Chairman, I asked the department this yesterday, and I know that they're not in a position to give us an answer on this. Where do you see the viability of hospitals over the next year with the current regs that feds have passed down to us on indigent care money, and how many do you see possibly going out of business as a result of that?
I'll do a rough translation of the money that's dealt with in the Indigent Care Trust Fund rule change, for example. If that program goes away, and that's a $400 million program with a $250 million net program, you equate that in terms of access. A typical rural hospital does $10 million in net revenue. If you lose $250 million worth of funding, that's the equivalent of 25 rural hospitals. Now, it won't all be rural hospitals, but it will be the equivalent of 25 hospitals worth of access. That's about $1,400, $1,400 per capita hospital net revenue, so you can go to a demographic and determine what you will actually end up losing. Where we are right now in viability, we have 4 little hospitals in the southeastern part of the state that we've chatted about on more than one occasion that are basically, at this stage of the game, not viable, and you can't name their names because if you do, they got runs with vendors on them and all sorts of issues. Those are the critical issues right now on those 4 or 5 little hospitals. But because of the way the CMO implementation is occurring and the fact that the PPS hospitals, which are the larger hospitals, did not have any funding to support them, they're in as much jeopardy now as the small rurals are. I won't call any names, but if you look around the state, you'll see some that in some larger communities that you would never think are being significantly impacted. And they're on this list of private hospitals right here. If you look, I'll give you an example. If you look at Cobb over in Royston, they have suffered tremendously as a result of this. If you look at Taylor down in Hawkinsville, Dan would tell you that he has suffered tremendously out of this whole conversion. So now we have 2 different levels of hospitals that are being impacted. We have the smallest hospitals, and now we have that mid-sized hospital that's in the 17 to 25 million range. And there is no safety net for them whatsoever.
Thank you, Jimmy.
Thanks, sir.
Alice Loper.
Mr. Chairman, committee members, good afternoon, staff. My name is Alice Loper, and I'm an advanced practice registered nurse in the state of Georgia. I'm a faculty member at Georgia College and State University in Milledgeville. I teach nurse practitioner students, and I also direct the Student Health Clinic, which is staffed by nurse practitioners. I'm here today to express some opposition to, it's my understanding that the Composite Board of Medical Examiners has requested money to fund a position to review nurse protocol agreements. Last year, a law was passed enabling nurse practitioners to be able to write prescriptions. We're governed or regulated entirely by the Board of Nursing. It has been always and continues in this new law that we must have a delegating physician to work with us, to approve what we do, to review charts. But when this law was passed, the Composite Board of Medical Examiners has put out a series of rules that are causing great impositions on physicians who choose to work with nurse practitioners. These rules are much more restrictive than the spirit of the law that was passed. It makes for cumbersome record keeping and great impositions on physicians. As far as the nurse practice agreement is concerned, the law as passed says that there must be one between the nurse practitioner and the physician, must be signed, must be approved by the physician, updated annually. The Board of Medicine is requiring that this document be sent to them for review and approval on an annual basis with a fee attached of $110 that is expected to be paid by the physician. That's for each site that the physician has a nurse practitioner working. Anytime you amend this protocol agreement, the amendment is to be sent to the board, and it's unclear if that requires a fee as well. One thing they are requiring in this agreement, the Board of Medicine, is a formulary of drugs that you're going to be able to use, and a formulary if you're going to accept drug samples from drug representatives. This can change on a daily basis. New medicines come out every day. New samples change every time the vendors come. So this just creates tremendous paperwork and may involve tremendous amounts of money. Then the Board of Medicine may not approve your agreement once you send it in. So it's my opposition that the spirit of the law is not being maintained in this request, that we even submit these agreements. And there are many other issues to their rules that are very, very restrictive. And I'm in opposition of this funding that they are requesting for this position that should not exist to begin with. Thank you.
Representative Stevens.
Thank you, Mr. Chairman. You know, I'm trying to remember last year when we passed this law, did we require in the bill that the physician that was approving the protocol be a Georgia licensed physician?
Yes. Has to be licensed to practice in Georgia and has to live within a 50-mile radius of the practice where the nurse practitioner practices.
How long have you been a nurse practitioner? Where my daughter went to college, by the way.
Oh, good. About 15 years. I've been a nurse for 35 years.
Thank you.
Representative Gardner.
One last question. I don't remember either. Does the law imagine that the medical board would take the responsibility for the protocols and?
No. The nurse practitioners are regulated entirely by the Board of Nursing. So these rules that the Board of Medicine have put out are impositions on the physicians, which we are required to work with physicians. That's not the issue. We always have and always want to. It's the fact that this has to be submitted, approved, possibly not approved, with a fee by the Board of Medicine.
So when the law was passed, you envisioned that that would be done by the nursing board as opposed to
the nursing board if they request it, but it states in the law that it will be developed and agreed upon mutually between the nurse practitioner and the physician.
And have the nursing board and the medical board been working together on how to implement this bill?
There has been efforts. I happen to serve on an advanced practice committee of the Board of Nursing, and we have made numerous attempts to meet with the Board of Medicine. Attempts have been ignored. Meetings have been canceled at the last minute. That has never occurred.
Ms. Love, we had yesterday, we heard from the department and Cancer Coalition, but we also had a chat with the composite board about that budget request, and I think I heard them say yesterday that they are going to very soon revisit this rule, and I would encourage you and others who are interested in that to keep up with that. I think they said it with, like in a week or so.
Good.
That they're going to do that, and certainly I know some in the General Assembly share, some of the concerns that you have expressed, and it's certainly my hope that they will revisit this whole matter.
Thank you. I'd just like to add that I appreciate the comments of all these people here in their efforts with health care and the situation with hospitals, and I appreciate your consideration of their concerns as well.
Thank you.
Thank you.
Pardon me. Good afternoon. My name is Nanette Turner, and I stand before you as a representative of the West Central Georgia Cancer Coalition. I'm the executive director. And I know that many of you have recently heard the great news that we got from the American Cancer Society, that it seems that cancer mortality rates are going down in the country. However, if you were to take a closer look at that data, you would find that that is not true for all populations, particularly populations that are in rural communities and specific minority populations. They're not having that experience. So disparities in cancer is a real problem. One of the things that we have done at the West Central Georgia Cancer Coalition is to try to address this particular issue of how do you get the things that we know work with cancer to those who need it the most. At the West Central Georgia Cancer Coalition, we developed a program called the Community Health Advisor Program, and it's not a new model. It's actually been used around the country for different kinds of diseases, but we took that model and adapted it in our community. Community health advisors are individuals, lay people who come from these specific hard-to-reach populations that we recruit and we train and we send them back into their communities to educate their neighbors, their circle of influence, their friends, their relatives about cancer screening and education, so that when we bring our screening to their communities, we're reaching the people who need it the most. They come and they take advantage of our screening. This program that we started has received national recognition, and in fact, the Centers for Disease Control last year sent down to our community a crew of cameras to follow us as we went out into the community to see how we do the work that we do. And that film that they did on us was actually featured at their National Chronic Disease and Prevention Conference as a model program. We also received funding from the Johnson & Johnson and Rosalind Carter Foundation to continue this work out into the community. And this past November, 3 of our board members and myself were flown up there to receive an award for the work that we do out in the communities, because we go out to the community and take this important effort to the people who need it the most. I submit to you that the way that it's proposed that our coalitions be funded might not be in the best interest of all Georgians. And I say that for this reason. The Community Health Advisor program that we started in our community, we actually shared our process with our fellow neighbors, with our fellow coalitions across the state. Northwest Georgia Cancer Coalition actually duplicated our program. They came down to our area, got trained, went back up to Northwest Georgia to do the same thing. And Diane Fletcher's group down in Southwest Georgia actually duplicated our program, and that's actually a part of what was featured in that CNN documentation that she talked about, and the program in Baker County. They utilized our programs. So when we're being asked to compete against one another, it's actually not in our interest to share these kinds of things, because we're trying to fight for money. So I think that if we all had core funding, basic core funding, that allows us to share openly all the things that we do, so that everybody can have access to the very best that Georgia has to offer, it's really in our best interest. And that's all that I have to say. Thank you.
Representative Hughley.
Thank you, Mr. Chairman. This is our area of the state, and we're very concerned about our cancer coalition. And in full disclosure, my husband is the president of the West Georgia Cancer Coalition, and they do very good work, and we do need to provide a mechanism where we can continue the work that we have. And we know that the more rural the area, the higher the incidence of cancer, because of a number of factors: education, access to health care, on and on and on, socioeconomic status, on and on and on. And I think the point is being well made today that we need to revisit this. So we appreciate you all being here.
Thank you very much.
Thank you very much. That's a good picture of your husband in his report. Representative Hughley. That concludes the testimony from people who signed up. I detect folks have been trying to get things going here, and if Fletcher, if you want to check with them and see if y'all going to show the CD or whatever it is.
And this was, as was mentioned, the CNN special that was nationally broadcast and highlighted in general. It was Lance Armstrong and had led this and highlighted prevention and screening and how that is cost-effective and saves lives. This is just a little blip that actually shows you the navigators going into the community that Nanette had mentioned. That DVD is the full DVD is in your packets of information.
We have a couple of other people who have requested time to speak before committee, and I'm going to allow that. We scheduled this meeting from 1 to 4, and we do have a little bit, not that these two are going to use up the remaining time, but how we're coming with the... If you're still having issues, let's have Frank Rump, I think, requested to speak while they getting the technical equipment squared away.
Thank you. I'm the CEO of the East Georgia Cancer Coalition, based in the eastern part of the state. We're bordered by Banks County in the north, Emmanuel in the south, Hancock in the west, and the border at the east, with UGA and MCG as a part of our particular coalition, and was a part of the planning and the establishment of this particular coalition. I'd like to just ditto what has been said, and I won't be redundant because there's just no need. We too are one of the younger ones, younger in the sense that we just begun to really get organized again when I took over as CEO about a year and a half ago. We realized that there is a need in cancer. I've always realized it because I've spent 24 years working for DHR in the Division of Public Health, and was once director of the entire cancer state program, entire program for the state for 10 years, and have always had a passion for cancer prevention and early detection and treatment and research that goes along with it. I don't want to say too much because I came in late, but I was over sharing this issue and talking with Representative Harbin, and he's supportive. And when I left, he told me to, now you make sure you talk to Mickey Chanel. So I guess you've gotten all that information that you need on this. Right. But I have some handouts that I'm going to give to that will share the information that I want to share with the committee. I just want you to know that I'm here and that I'm very supportive of the regional coalition and the entire model for this state, including the Georgia Cancer Coalition. This is an opportunity for this state to be a real model nationally, and the regional programs will be the conduit for bringing those national standards to the local region. Cancer centers can't do that. Only the regional programs can do that. And so we will anticipate and hopefully get your support in this effort. Thank you.
Thank you, sir. So let me ask you one quick question that relates to the funding. There's been talk with the previous Cancer Coalition presenters about, you know, what percentage of money as it relates to state money should be so-called core funding, which keeps your doors open and the lights on kind of situation, versus some portion of the money being earned competitively through outcomes or other things. Tell me how much money you think in your region it would take as core money for you all to do your fundamental work.
Well, we kind of start out with the $300,000 figure, and that's what we really think. We can add to that through our granting process by obtaining monies, but $300,000 is what we need. We figure that would allow us to have the staff and the support that we need. Now, we don't want a large staff. We're not planning on a large staff. What we're planning on doing is collaborating and coordinating with partners within the community so that we can bring everyone within the community who has a mission with cancer prevention and early detection in it, bring those people together so that we can talk about how we put our resources together so that we don't duplicate at the local level. And I think that was one of the primary reasons for for creating the coalition. But we do need $300,000 core funding at this point. It is hope that over the years, as we move forward, that we can expand our region through our own efforts and other grants monies.
Thank you. Gail Benner.
I love the way everyone has said, come see Mickey, which we have done too. I'm Gail Bina, and I'm the Executive Director of the Central Georgia Cancer Coalition. We represent 25 counties in the heart of Georgia, 625,000 people. Our coalition is composed of 23 hospitals. Many of them are the rural hospitals that some of you have been talking about, particularly Dan down in Hawkinsville. We discuss a lot with him. We also represent physicians, nurses, healthcare providers, 8 major academic institutions, businesses, volunteer agencies, faith-based organizations, public health, and over 300 committed volunteers that are very energized around cancer. The Central Georgia Cancer Coalition was designated by the state of Georgia as a regional program of excellence in 2003. Since that time, we have received from the state, including startup funding, $573,000. With that state money, we have had a return on investment to the state of Georgia of 236%. For every dollar we were given, we've returned that much in grant funding and outside funding for this organization and effort. Last night, I attended an educational lecture about tobacco addiction sponsored by Pfizer Drug Company. The cancer researcher presenting was from MD Anderson in Texas. After the session, I had an extensive opportunity to talk with this cancer researcher. He and I are from the same hometown of Pittsburgh. Some of us are from Pittsburgh. But being a good Georgian, being concerned about cancer, and being a recruiter to the state, I said, would you be interested in coming to Georgia to bring your cancer research here? This is his reply to me, and I'm going to quote. He said, one of the best things George Bush ever did as governor of Texas was to set aside tobacco settlement money for cancer prevention, care, and research. This particular researcher at MD Anderson is receiving $1.7 million over a 3-year period as his infrastructure support for cancer research. He said that the majority of cancer research money is coming from private sources. He said that's also true for many other medical research, whether it's stem cell or Alzheimer's. But he said the government support is allowing the infrastructure for those operations to allow them to go out and to seek outside funding. Much of the cancer research will take 15 years to get down to our rural places in Georgia. It takes 15 years to reach it to our rural counties and to the people that we live and serve. Cancer research is a very noble cause for Georgia, but we are not the only state in the union that are competing for these researchers. Many states are fighting for the top minds and the dollars that follow these researchers into the state. But the Georgia Cancer Model of Regional Programs of Excellence is nationally recognized benchmark model, extending cancer care programs and access to every Georgian. Support for these programs is vanishing. We were told in June of 2006 that in the year 2008 we will receive zero funding from the state for support for these programs. Just as the few research institutes in Georgia need infrastructure support to attract the best minds, so do the regional programs of excellence to attract the best programs that meet the needs of our local organizations. Whether it's a cancer summit for 500 family practice doctors in Georgia, that was an idea from the Central Georgia Cancer Coalition. Whether it's a cancer summit for 150 pastors and religious leaders, a breast cancer awareness luncheon for 300 African American women, prostate cancer leadership committee, teen health forum to prevent tobacco initiation, the first Georgia American Cancer Society patient navigator at the Medical Center of Central Georgia, the first 2 certified cancer exercise specialists in the state of Georgia, or over 300 free mammographies for uninsured and underinsured women, including paying Dan in Taylor Regional for his services. The Central Georgia Cancer Coalition is dedicated to making a difference for the outcomes in the 25 counties in our region. Cancer has touched every one of us in this room. Every family in Georgia can share a cancer story with you. The words, "You have cancer," will be heard by 1 out of 2 men in Georgia and 1 out of 3 women. Cancer is still the #1 killer, you won't hear this in the media, of adults under the age of 80. It's the premature one that yanks those people out of our families. Cancer does not discriminate, but the allocations of limited funding does discriminate. We are asking to be able to do today what we know works. Let us work with the money and the opportunity we have to extend it to every Georgian. Thank you.
Thank you. We apparently are still having technical difficulties, and so I might suggest members of the committee, I think we have that CD or something in the packet. So, sorry. Is there anybody else that did not sign up that would care to address the committee? Yes, sir.
Thank you, sir. My name is Tom Strickland. I'm a nurse practitioner from the northwest part of the state above Dalton. And I appreciate that.
What?
I'm a nurse practitioner from the northwest part of the state above Dalton. Tom Strickland. I just want to talk with you for a moment about the draconian regulations recommended by the Board of Medicine and how they are having a negative impact on our ability to practice and to take care of people. For 25 years, I was educated in this state at Georgia State University as an MP. I've practiced in every possible environment: county, rural health department, emergency room, military at Fort Benning and Fort Gordon, now to a small practice in a small town that has a significant impact on the health care of the community. And for 25 years, I've been calling in prescriptions, which requires several minutes of time per patient and the possibility, large possibility, frequent possibility of error. Just this week in the newspaper, a national company that's offering services to go completely to email for prescriptions to cut out some 770,000 prescription errors per year points to the light of the fact that having to call in prescriptions, being forced to do this, is a real hazard to the public. It's a real inconvenience to our efficiency to practice, our ability to take care of people. It's time I can't spend taking care of people who are, in fact, becoming older, in fact, having more complex medical problems as the demographics of the country and its population change. It's my opinion that the Board of Nursing should establish the rules and regulations for the practice of nurse practitioners, that the Board of Medicine's recommendations, many of them are very good recommendations, and I agree with them, and some of them are very difficult regulations, such as requiring a physician to sign 100% of my charts, using up his precious time and my precious time, when in fact we've been practicing with great efficiency and a great safety record and great patient satisfaction rates for 25 years. These are some of the situations, some of the examples of that bill which are moving us far backwards in our ability to care for Georgia's citizens. So I ask for you to look at this situation in consideration of the possibility that this bill can come up to be reviewed, that these regulations that are being from the outside recommended upon us, that are not necessary, that are fixing something that's not broken, that are making practice difficult relationally between the nurse practitioner and the patient, the doctor and the patient, the doctor and the nurse practitioner. This is not a time in our country and certainly in our state when we need to make health care less efficient to fix a problem that's not broken. Thank you for your time very much.
Thank you, sir. Yes, sir. Yes, you may.
Good afternoon. I'm Dr. Jim McNutt. I'm the medical director for the Composite State Medical Board, and I was involved in a number of the meetings between the nurses and the physicians and the different legislators when this nurse practitioner prescribing bill was developed and passed last year. So I do think I have a pretty good idea of what a number of different people said in the meetings, and as I think was stated yesterday during the meeting, we are getting together a group of interested people to see if there are some issues that we can continue to work on. But some of the facts that are being stated here simply are not what the law says. For instance, that we don't need a position for the to receive and review the nurse protocols. That's from the law. We were trying to get together the figures for the meeting today, but our equipment is down, so we haven't been able to get the figures that the Executive Director, LaShawn Hughes, has said she would get you. But specifically, or quoting from the law, it says that the medical board must determine after review of a filed nurse protocol agreement if such nurse protocol agreement fails to meet the accepted standards of medical practice as established by the board. So that's in the law, and that's the position that we had originally discussed funding and developing. If we can't have a position to be able to allow us to review the nurse protocols, I don't see how we're going to be able to review them and to pass on them. And I don't see how the law can actually be implemented. The law does require that we receive and review them and require changes as necessary.
Thank you, Doctor. I don't think that anybody has suggested that what the board has done is outside of what the law specifically asked them, directed the board to do towards the regulations. I guess a lot of the observations that I have heard is not whether or not you had the board had the legal authority to do what you did. The General Assembly clearly indicated that rules and regs would be proclamated by the board. Having said that, I think there's a legitimate debate here about what the actual intent of some of the rules appear to be, whether they are in fact the only way to go in terms of having a good medical outcome. Certainly that's what everybody wants. But also, it was a clear intent, I think, of this General Assembly that we wanted to become the 50th state that has nurse prescribing in this state. And I appreciate the fact that y'all are willing to relook at this and also take into account some of the criticism I know you've heard, and certainly we as legislators have heard, that some of the rules, while certainly legal, sometimes stand as a barrier to providing that care. And whether or not that's true, I'm not, as chairman of this committee, standing up here and saying I'm some expert on all that. I'm not. But we want quality care. I think it's certainly fair to say in the General Assembly, but we also, we want nurses to be able to, nurse practitioners to be a part of delivering that care in this state. And I appreciate y'all agreeing to get some people together who are interested in this. And again, we've heard from some people that when that time came, they actually didn't have a seat at the table. I hope that seat will be available to the interested people on both sides of this issue when you all take a look at it. And I'm appreciative of y'all agreeing to do that.
And I appreciate that. I am not the person directly responsible for setting up the meetings, but I have been told that the medical board has repeatedly reached out to different organizations, and we simply have not been able to arrange for the meetings. And I don't know the details of that, but there is, and what we would like to do is to specifically go through the details of the law and the protocol. But if we don't have the money appropriated for a position, we're not going to be able to do what the law requires us to do. And I think I heard the lady state earlier that there was no need for the medical board to review the protocols, and therefore there was no need to spend money in a position to do that.
Yes, sir. And certainly I also want to make it clear that this subcommittee has budgetary responsibility for this, and that's how and why we're having this discussion. that we do not set scope of practice in this committee. There's another committee that has that responsibility, and we're not going to get involved in trying to do that at all. But if for purposes of, I guess, trying to be sure everybody knows what's going on, I mean, if somebody wanted on either side of this issue to be involved and attend the meetings and have input, could you give this committee and members of the audience a name and a phone number that they could call to find out when the meeting's going to be and what they can do and that kind of stuff?
They could actually call my number directly. My direct number is 404-657-6496, and I will at least be able to direct them to the person if I don't have the answer at that time.
That's 404-657-6496.
Right.
Again, the commissioner yesterday indicated that this process might start reasonably soon. Do you have any notion when that might be?
In the next month or so. We have, since the rules were just effective in January 1st, we've worked very hard to get the infrastructure going, and we have been using temps to get the process up and going, but it's going to take a knowledgeable person to organize this information, enter it into the computer, and to present it to the board for the board's review.
Yes. Representative Gardner has a question, and follow that Representative Stevens.
Do the fees that the physicians pay who have these nurse practitioners, is it your intent that they will eventually cover the cost of this administrative responsibility?
Right. According to state law, and I'm not the budget person, we raise a certain amount of money that goes into the general treasury. You all appropriate back the amount of money that our budget. In hiring a new position, the point of the fees is to raise some money, the correct amount of money, to make that position and the fringes that go with that basically revenue neutral, so that we're not sucking money out of the budget somewhere else, so as to balance the expenses of the new position with the state law mandate that we have it funded.
I guess my question is, in a subsequent year, then would you raise the cost of license renewal to cover this cost, rather than use additional state funds?
That it could be done. Well, it still have to be appropriated. It could be done through as long as we raise the money. It doesn't matter, where it comes from.
Right. I guess Ms. Hughes was going to try to provide for us an indication of how much money went into the general fund and how much the expenses of the board were, so that we'd see that you were self-funded.
Well, we return at least half again as much as we collect. I think we probably collect about $3 million a year, and we spend roughly $2 million a year. So at the present time, we probably return $1 million or so or more, at least that to the or don't get it back from the funding.
Thank you.
Representative Stevens.
Thank you, Mr. Chairman. Mine is kind of a catch-22 question, because I'm reluctant as a legislator elected by the people whose taxpayers I'm responsible to spend to vote for an additional position before rules and regs are promulgated to carry out exactly what the letter and the intent of the law for nurse practitioners was to begin with.
When I was involved in the meetings that resulted in the legislation being passed, I was made to promise that if this were done, that the medical board would jump on it, pass the rules, and get it going, and that's what we've tried to do. The rules have been promulgated and reviewed multiple times by the Attorney General's office and have been adopted. We felt like we had to get something out there to comply with the law, but just because rules have been promulgated doesn't mean that they can't be modified, which we are certainly looking at doing that.
Thank you, sir. Anybody else? Do we have an update on the... Okay. Anybody know how to turn the lights down?
That gives you the idea. Thank you. I'm sorry we couldn't hear.
I'd like to thank the members of the committee for being here. I know you all have busy schedules and conflicting meetings oftentimes, and the chair is very appreciative of that. I'm very also appreciative to each of you who have, many of you travel long distances to come and talk to this committee about your concerns. I very much appreciate that, so does the committee. We stand adjourned.